Very good morning. Today we'll be discussing a very rare tumor, a typical teratoid rhabdoid tumor of the central nervous system, which comes under the embryonal tumors. So the outline of today's talk includes introduction, clinical features, imaging findings of atypical teratoid rhabdoid tumor and its differential diagnosis, the macroscopic and microscopic findings, Immunoprofile, genetic profile, and the prognosis. So coming to introduction, CNS embryonal tumors encompass a heterogeneous group of malignant tumors composed of immature cells resembling neural progenitors. These are mainly but not exclusively disease of childhood. Medulloblastomas originate from the cerebellum or the dorsal brainstem. So these form the major chunk of the embryonal tumors, whereas the other CNS tumors may arise across the neuraxis. So, these are the molecular subgroups of medulloblastomas, and these are the other CNS embryonal tumors, out of which we'll be seeing a typical teratoid rhabdoid tumor. So by definition, it is a high-grade malignancy composed of poorly differentiated cells and a variable number of rhabdoid cells with potential to differentiate along neuroepithelial, epithelial and mesenchymal lines. Genetically, these tumors are characterized by biallelic inactivation of SMARCB1, which is also known as INI1, or rarely in less than 5% of cases, SMARCCA4. So this always corresponds to CNS WHO grade 4 tumors. Coming to epidemiology, they account for 1.6% of all pediatric CNS tumors and for about 10% of CNS tumors in children aged less than 1 year. There is slightly male preponderance. Now, clinical features vary depending on age, location, and size of the tumor. Infants present with lethargy, vomiting, and or failure to thrive. Head tilt and cranial nerve palsy, mostly of the 6th and the 7th nerve paresis, is noted. Children with more than 3 years of age present or complain of headache and hemiplegia. Localization, these can be present anywhere in the neuraxis. Supratentorial tumors are more common with increasing age and are often located in the cerebral hemispheres and less frequently in the ventricular system, suprasellar region, or the pineal gland. Infratentorial tumors can arise in the cerebellar hemispheres at the CP angle and the brainstem. Spinal cord localization is rare. Even adults are affected, but this is very rare, and these tend to occur in the cerebral hemispheres and the sellar region. CSF seedling is seen in 1/3 of all the patients at the time of presentation. So it is very important to get the imaging of the complete neuron. Imaging findings. On MRI, this tumor presents as roughly spherical, irregular, lobulated or heterogeneous bulky mass measuring about 1 to 3 centimeters in size or even larger in infants or young child with mixed solid cystic components. On T1 weighted images, this is heterogeneous, isointense to brain and may have hyperintense hemorrhagic foci. Cysts are slightly hyperintense to CSF. On T2 weighted images, it is heterogeneous, hypointense foci of hemorrhages and hyperintense foci of the cysts. On flares, these are solid tumors, isointense to hyperintense, and cysts appear hyperintense to CSF. Leptomeningeal deposits or spread is common in 15 to 20% of cases at initial presentation, and these deposits may be diffuse, linear, or multiple nodular. Brain-to-brain parenchymal metastasis may also be present. So the differential diagnosis on imaging could be a medulloblastoma. Now, medulloblastoma is a posterior fossa tumor typically, and ATRTs are more likely to have cysts than medulloblastomas. Second DT is the ependymoma. It's a plastic tumor which extends out of the fourth ventricular foramina. Calcification is present, cysts and hemorrhages are common, and it shows strong heterogeneous enhancement. The third DT is the choroid plexus papilloma. Now, this is an intraventricular mass with homogeneous enhancement. The fourth is the high-grade glioma. There may be a exophytic growth from the brainstem. And the next is the teratoma, which is more often in the pineal or the paracellular location. Now, these are heterogeneous masses on imaging, and this may be due to calcification or hemorrhage. So, we'll be seeing three cases which have been sent to our lab, Shanti Pathology Lab. I always request the neurosurgeons to please share the MRI of the patients, because then it becomes possible for me to document, and I can even show the MRI on my channel. So this case was sent to me by Dr. Ivcharian from KIMS Karad, and this is a 6-month-old child who presented with vomiting and drooping of the left upper eyelid for last 12 days. And you can see this is a large lobulated heterogeneous mass in the cellar and the supracellar region. Now, this is another case, and this is a 1-year-old child who was operated by Dr. V.S. Pawar from City Hospital, Kolhapur. And you can see this is a large, this boy is 1 year old, and he presented with lethargy, vomiting, failure to thrive, and increased head circumference. And there is a large heterogeneous solid cystic mass in the right frontal lobe, causing compression over the adjacent structures. Now, again, this is the third case which was operated by Dr. Virendra Pawar sir, V.S. Pawar sir from Kolhapur. And this is a 3-year-old girl who was brought by parents complaining of vomiting, irritability, delayed milestones. And again, you can see this is a large heterogeneous mass in the left cerebellar region. So we went ahead with the intraoperative squash for the third case. So you can see this is a highly cellular tumor composed of numerous immature or the primitive cells, and some foci showed these presence of rhabdoid cells. You can see these are round to oval nuclei with eccentric nuclei with abundant eosinophilic cytoplasm, and you can see the background here is hemorrhaging. Macroscopic findings. These are soft to firm pink-red masses, and they may be tan white due to the mesenchymal component. More amount of mesenchymal component gives firmness to the tumor. Areas of necrosis and hemorrhage are often present. Coming to microscopic findings, this is a heterogeneous tumor difficult to recognize solely on basis of histopathological findings. Population of rhabdoid cells and variable component of primitive neuroectodermal, mesenchymal and epithelial features. Sheets of densely packed immature cells with high nucleocytoplasmic ratio are present. The diagnostic feature on histopathology is presence of the rhabdoid cells. Now, these cells may be small cells with scant cytoplasm to large typical rhabdoid cells with eccentric nuclei and extensively homogeneous eosinophilic cytoplasm. These cells have well-defined cell borders with abundant cytoplasm and eosinophilic inclusions. Eccentric vesicular nuclei with prominent eosinophilic nucleoli, may be present. Mitotic activity is numerous. Geographic necrosis may be present and often diverse with mixed histologic appearance composed of epithelial, spindle, chondroid component may be present. And the vasculature, especially in the adult type, may be staghorn-like vasculature. So coming to the histopathology slide of the case 3, now you can see this is a highly cellular tumor with lot of primitive component. These are the areas of necrosis, numerous mitotic figures here, and these are the rhabdoid cells with typical large round vesicular nuclei having prominent nucleoli and abundant eosinophilic cytoplasm. So these are the sheets of rhabdoid cells. Now this area shows glandular architecture along with the primitive component, and these are again the sheets of rhabdoid cells. So coming to immunoprofile, a typical teratoid rhabdoid tumor expresses broad spectrum of immunoreactivities. Rhabdoid cells express EMA, vimentin, and SMA positivity. Now, the diagnostic feature of this tumor is the loss of INI1 expression in the tumor cells. Now, you can see the tumor cells here are negative, and the positive control is the endothelial lining, the endothelial cells. So, you can see it is nicely expressed in the endothelial lining. Now, synapto and cytokeratin may be focally expressed. These are negative for LCA, c-KIT, PLAB. Now, these are to rule out the germ cell tumors, GFAP for the glial cell tumor. The myogenin is also negative, and the proliferation index in the case 3 was 40 to 45%. Usually, the Ki67 index in the ATRTs is about 50%. So we give a diagnosis as we render a diagnosis of atypical teratoid rhabdoid tumor, CNS WHO grade 4. Now, what are the differential diagnoses we should consider on histopathology is medulloblastoma. Now, compared to this, the cells are more larger or typical hyperchromatic nuclei, and MBs, medulloblastomas, have diffuse synaptophysin positivity with retained nuclear INI expression. Second is the choroid plexus carcinoma, especially in infants. These are composed of poorly formed sheets of pleomorphic tumor cells, and there is necrosis. EMA is often negative and again retained INI1 expression. Rhabdoid meningioma is rare in children, and EMA expression is focal to absent in high grade subtypes. Again, INI1 is retained INI1 expression is very helpful. Then coming to the other CNS embryonal tumors, these lack rhabdoid inclusions, and there is diffuse synaptophysin positive with retained INI expression. Germinomas are often located in the pineal and the suprasellar regions, and these lack rhabdoid inclusions, and these are typically positive for the germ cell markers such as c-KIT, OCT3/4, PLAB, and INI1 is again retained in the germ cell. Diagnostic molecular pathology. Loss of SMARCB1, that is INI expression at the protein level, is seen in most cases of ATRT. Mutations in SMARCA4, that is BRIG1 gene, are rare. Loss of all or part of chromosome 22 is frequent. Gene expression and DNA methylation profiling identifies 3 potential subgroups that can potentially aid in the subgroup-based therapies. So the subgroups are as follows: ATRT-TYR, which shows overexpression of tyrosinase, patients of younger age group, median age being 12 months, majority present with infratentorial location, whole or partial loss of one copy of chromosome 22 accompanied by point mutation in SMARCB1 on the other allele, Next group is the ATRT-SHH, that is overexpression of sonic hedgehog and notch pathways. Most display compound heterogeneous point mutation in SMARCB1. Further subtyped by supratentorial, that is ATRT-SHH1 or infratentorial ATRT-SHH2 localization. ATRT-MYC is found in older patients, that is median age is 27 months, and there is overexpression of MYC oncogene, homogeneous broad loss of SMARCB1 with lower overall DNA methylation levels. Next group is the adult cellular ATRT, and this is a clinically distinct entity. However, DNA methylation is similar to ATRT mixed subgroup. Coming to prognosis, these patients have very poor prognosis, and you can see there are various trials, that is of the German group and the Children's Oncology group or the European Rhabdoid Registry trial group. So the overall survival or the event-free survival rate is, you can see, varies from 3 to 5 years. Prognostic value of ATRT subgroup needs further validation. The non-ATRT TYR profile has worse prognosis, and there is higher survival in patients with ATRT SHH group. Take-home message: atypical teratoid rhabdoid tumors are high-grade malignant embryonal tumors of the central nervous system composed of primitive undifferentiated cells with varied number of rhabdoid cells. Now these primitive cells may show differentiation towards the neuroepithelial, epithelial or the mesenchymal components. These correspond to CNS WHO grade 4. Imaging findings: these are large heterogeneous masses. They may vary from 1 to 3 centimeters in size or maybe even larger. The tumor has variable or variegated appearance, heterogeneous appearance because of presence of hemorrhage, necrosis and multiple cysts within. Coming to the macroscopic findings, these appear as pinkish red masses. These may be soft to firm depending on the amount of the mesenchymal component present, and often there are areas of necrosis and hemorrhages. Now coming to microscopy, the tumor is composed of primitive cells with a variable number of rhabdoid cells. Now the rhabdoid cells may vary from small rhabdoid cells to typically large rhabdoid cells having eccentric nuclei and abundant amount of dense eosinophilic cytoplasm. The nuclei are large vesicular with prominent nucleoli. Numerous mitotic or brisk mitotic activity is present. Areas of necrosis and hemorrhages are present. At a times there may be glandular differentiation in the tumor as well. Glandular or myxoid stroma may be present. Then coming to immunohistochemistry, the diagnostic finding is iron loss in the tumor cells. The positive control is taken as the endothelial lining or the endothelial cells. Molecular genetics, there is biallelic inactivation of SMARCB1 and rarely SMARCA4. Now, 3 molecular subgroups have been identified depending on the DNA methylation. Prognosis, treatment and prognosis: intensive multimodal treatment is given to patients with ATRT, that is chemotherapy with irradiation, and the prognosis is poor. Coming to this non-ATRT TYR profile shows work prognosis, and higher survival is seen in patients with ATRT SHH group. If you have any queries about atypical teratoid rhabdoid tumors, or if you need to discuss any case, you can email me on the email ID which is mentioned here and ask your queries on the comment box. Thank you very much.